Namaskar, good evening.
Good evening, sir.
At the outset, I welcome all of you from myself, Dr. Jay Bhandakar, State Convener Mahaiap, and President Dr. Hemant Gangulia, sir, and Dr. Amol Kaur in absentia, and our digital wizard core, Dr. Neha Singh, and my moderator, Dr. Samir Sadavate. And when you thought of doing this Mahasubset Connect, I'm very fond of always about the endocrinology, which is an amalgamation of physiology and pathology itself only. So I welcome you again on this beautiful, I can say, innovative seminar where our two young endocrinologists from India, I can say, Tushar Godbole from Nashik and our own Nikhil Shah from Mumbai. So they are going to blast us from the name of the event is endocrine pulse. तर आपल्याला मोती वेचायचे आहेत आणि spotters. It's not an individual disease we're going to talk about, the guide of the spectrum of the disease of the endocrinology. So I'll say I studied. So what are the spectrum? I will explain it in 1 minute. It starts from most of the patient referred to the endocrinologist are the short stature, and you have to differentiate between nutritional, endocrinal, and non-endocrinal. Then second are the all whether it is a long stature, suppose heighted जर असेल तर तो एंडोक्राइनिक का नॉन एंडोक्राइनिक का ओबीज आहे. Later we come to the patients of the diabetes. Yes, there is a long rise in increase of type 1 diabetes as well as type 2 in the corona period. And third, other the hypoglycemia. In infantile, there is all carbohydrate metabolic disorders with that kind of hypoglycemia, which is non-keto is very common, as well as that hyperinsulinemia and others. And so in the hypothyroidism is the early detection and treatment. So these are the common diseases which presents to the endocrinologist, and these our two young endocrinologists going to give these glimpses of this, right? So I welcome ask our own IIP president, Mahaiap president, Dr. Hemant, to give his thought within 1 minute, and later on Dr. Samir will introduce both speaker, and we're going to start with our own session. Thank you.
Thank you, Jay. Good evening and namaste to respected young dynamic faculty, both Dr. Tushar sir as well as Dr. Nikhil sir. And we acknowledge the presence of our EBCIP, Dr. Bela Verma madam, as well as international attendee in this session, Dr. Melkamu Meza from Egypt, as well as all the dignitaries on the dais and all the viewers who are there on the Mahaiap YouTube channel. I will request everybody to subscribe this Mahaiap YouTube channel because it has all the recordings of the past events as well as forthcoming events will be there. And to say about today's session, already Dr. Jay has explained, but one thing we should confess, this endocrinologist always say, and I'm sure that presentation will start with our charts, and they always say to maintain the chart, and we should confess that we are very, very poor at it, and we don't maintain the charts, and all the crux lies in the charts. I think so all we should start. I think so this is a third generation of the endocrinologists which are stressing upon, right, making the charts in our files. So with that opening remark, I welcome everybody, and let us enjoy this session and learn new things. And always, each session is always a learning one to each one, how many years you may be in the practice. Thank you very much.
Okay, Dr. Samir, over to you.
Hi, am I audible to you, everybody?
Yeah.
Yes,
Yeah.
yes, Samir.
Okay. So Dr. Tushar Godbole is from Nashik. He is a pediatric endocrinologist and adolescent endocrinologist, particularly from the North America, north of the Maharashtra, sorry. And hello.
He's as good as from North America. No worries.
Yeah. I want to say actually North Maharashtra, but that's fine. He will be at some point in North America, so very famous. I am very sure on that part. The way, if you see his academics and his curriculum also. So he's also attached to the associate professor at Vasantrao Medical College Hospital in Nashik, and is a visiting consultant in Mumbai, Dhule, Aurangabad, and at various places, and has been a contributor for the academics, including the 4 national and 5 international publications. So over to you, Dr. Tushar Godbole, sir. And then we'll first welcome Dr. Nikhil Shah, sir, afterwards.
I think
okay, I'll just finish right now. So Dr. Nikhil Shah, sir, he is the consultant pediatrician Please go to next slide, please. An endocrinologist has been working with Fortis Hospital and various other hospitals, including Bhatia Hospital in Tardev in Mumbai. And as a visiting consultant is a LTMMC Sion Hospital and in KJ Somaya Medical College and Hospital and Business Center. He is associate professor in pediatric endocrinology at Jahangir Hospital in Pune. Has major contribution in the index public journals, including 18 published papers and 1 textbook chapter. So welcome to Dr. Nikhil Shah, sir. So let's start with initially with Dr. Tushar Godbole. Over to you, Tushar Godbole.
Thank you so much. And at the onset, me and Nikhil, both of us are actually thrilled to be here. And as the session is supposed to be, a rapid fire spotters, so we'll take you through a series of cases, and at the end of every case, there will be one strong take-home message. And I invite Dr. Nikhil to start with the first case. Nikhil, over to you.
Yeah. Good evening, everyone. At the onset, I'd like to thank the Mahaiap team and the executive board for giving us this opportunity. So what we've done is we've created some basic spotters, starting from a little bit easy, and we've just built up the level, and we'll slowly build it up and try to make it a bit difficult to what common cases we see in the general pediatric OPD as well as in the endocrine OPD. So coming to the first case, so this is basically few growth chart cases which we'll be discussing. So this is a girl, 6, who presented with us with a height of around 102 centimeters and a weight of around 16 kilos. Now coming to the first very basic question, is the child short or not? Yes, the child is short because the height is less than the 3rd centile here. Now, what is the next, which is the next important step in examination? What should we do next? I think the next most important step here is the MPH plotting, that is the mid-parental height plotting. So mid-parental height is nothing but average of the parent's height minus 6.5 in cases of girls and plus 6.5 in cases of boys. So this is how we plot the mid-parental height. Now the recent IAP charts, which are the pediatrician IAP charts, provide this mid-parental height percentile calculator, which makes the calculation very easy. So what we have to do is just join the father's height and the mother's height, and we get the mid-parental height percentile. So if you're seeing here, my mid-parental height percentile is lying between the 3rd and the 10th centile. This is after doing the calculation. If I just join the heights, that is the same thing I'm getting. So this has been simplified in the recent charts right now. So now, what is the cause of short stature here? So we've got a girl child who's short for the 3rd, who's shorter than the 3rd centile, but height is within the mid-parental height target range. So this is nothing but familial short stature. As you can see that the height is falling within the mid-parental height target range. What investigation should be done? I think the only investigation that should be done is the bone age. So bone age will be equal or slightly advanced to the chronological age. So I think the take-home message here will be, I think mid-parental height plotting should be done in every child because it will give us a clue as to what the cause of the short stature is. Coming to the second case now, this is a 14-year-old boy with a height of around 145 centimeters and a weight of around 35 kilos.
Dr. Nikhil, his follow-up is required in this familial short stature for the further measurements?
Yes, sir, because we do not know whether the child is going to develop some other condition like hypothyroidism or not. So once a year, at least once in 2 years, we should keep plotting the height. If the child is falling along the same centiles, I think we should be fine, sir.
Oh, thank you.
So what would be the height velocity? I mean,
height velocity will be like a normal child, sir. Normal child, ma'am.
Yep.
It will be slightly less to normal. So 4 to 5 centimeters a year.
If I were to add a little bit to that, in this case, we believe that the parents are short as their constitution and not as a result of any disease. So, for example, the father has some disease and as a part of that disease, he's short, then the next generation might be actually tall. So a serial follow-up is very, very essential because we might just attribute it to be familial short stature. And I completely agree with Nikhil that we have to follow up over a period of time. Yeah.
So coming to the second case, this is a 14-year-old boy with a height of around 145 centimeters, weight of around 35 kilos. Now, is the child short? Yes, the child's height is less than the 3rd centile. and the child is short for the mid-parental height target range. So when I'm dragging this ahead, the child is falling below the range of the mid-parental height target range. So what is the next step in the examination? I think one very characteristic feature we need to see here that the child is 14-year-old. So I think pubertal assessment is the most important examination here. We have the mid-parental height. So when we did the pubertal examination, the child is having some axillary hair. Pubic hair is stage 2 of Tanner staging, and testicular volume is just 4 ml. So child has just entered into puberty, and penile size is the stage 1 of Tanner staging. So just recapping the case, it's a 14-year-old boy, short with delayed puberty because he's just entered into puberty. So what is the most important investigation? Again, the most important investigation here will be the bone age. The bone age is going to be delayed by around 2.5 years. So in our case also, the bone age was delayed by around 2.5 years. So what is the diagnosis? 14-year-old boy with delayed puberty, short stature, delayed bone age. The diagnosis is nothing but constitutional delay in growth and puberty. How do we treat such children? So typically we wait till 14 years of age. If by 14 years of age, the height is lacking, puberty is lacking, we give a short-term testosterone therapy. So we give roughly 50 to 100 milligram monthly, 3 to 6 months, depending on the response. And following the response, you can see that the child who was lying on the last centile or below the last centile has reached within the target of the mid-parental height range. What is the most important history in CDGP? Mostly one or both parents usually have a history of CDGP. So this is the importance of, examination of the SMR staging or Tanner staging in the peri-pubertal or the pubertal age group, because it tells us whether the child is into puberty, late puberty, early puberty, all of that.
So, Dr. Nikhil, what instrument do you suggest that the pediatrician should be having in their OPD? So, and where to procure it from? Yeah.
So for girls, it's very easy because when you walk in, you can easily see whether there is any chest development or not. For boys, I think we need to look at the testicular volume. So ideally, we should look at the Prada's oxidometer. Prada's oxidometer, I think it is available on the ISPE website, sir.
Yeah, it is.
Yeah, so it is available on the ISPE website.
So it's for everybody's benefit. It's a string of beads with the smallest size is 1 ml, and from 1 ml 2 ml onwards we have sizes until 25 or 30 ml, and you just catch hold of the testicle of that child and compare it with the bead, and the nearest matching volume is the volume of the testicles. So 4 ml is the onset. Yeah.
So now coming to the third case, this is basically a 9-year-old child with a height of 120 centimeters. Weight is around 17 kilos. Now coming to again the age-old question, is the child short? Child's height is on the 3rd centile, but the child is short because the child's height is below the mid-parental height target range. So this is the advantage of taking the mid-parental height. What about the weight? The weight is way below the 3rd centile, and the weight is much more affected than the height. So now we are coming to the conditions of short stature, where weight is much more affected than height. So what are the examples? The common examples are malnutrition, undernutrition, or systemic causes like some renal disease, gastrointestinal diseases. Now coming back to our case, our child is short, but weight is much more affected than the height. In addition to that, the child has some poor appetite, frequent loose stools, and there is pallor. So what is the diagnosis? So most likely this is a gut pathology. So the diagnosis was celiac disease. We screened by serology and confirmed by an endoscopy and biopsy. So treatment, as all of you all know, it is a gluten-free diet, and the response is like beautiful, like a GH therapy response. So the child grows very, very well. Once the gluten is avoided, grows very, very well. What are the common causes of short stature with anemia? So iron deficiency anemia, hemolytic anemias are there, but I think we should never miss something like a celiac disease or a CKD, that is a chronic kidney disease. So any case where weight is much more affected than the height, in a case of short stature, think more in terms of systemic causes than endocrine causes per se. Coming to case 4 now. So this is a 4-year, 3-month-old girl, height of 80 centimeters, weight of 10 kilos. So is the child short? Yes, because the child's height is less than the 3rd centile and the child is way below the mid-parental height target range. as you can see that the height is significantly affected than the weight. So what are the conditions where height is significantly affected more than the weight? As Khadilkar sir used to teach us, there are only 3 conditions which fulfill this chart. One is endocrine. So this is always pathological. It has to be either endocrine, syndromic like Turner syndrome, or skeletal dysplasias. These are the 3 most common conditions where you will see that the height is much more affected than the weight in a case of short stature. What is the next most important investigation? As usual, the next most important investigation will be a bone age. Bone age will be significantly delayed in endocrine like a growth hormone deficiency or hypothyroidism, might not be very delayed in syndromic or dysplasias. So on physical examination, you can see that this child is having some frontal bossing here. There is a mid-facial hypoplasia. There are very delicate hands and feet, so really small hands and feet. And the child has a typical high-pitched nasal voice. On probing for history, we found that the child was born of a breech delivery, and the height started getting affected after first year of age. First year, the child was fine, but from second year onwards, the parents noted the child is not growing too much. We did the bone age was really delayed. So chronological age is 4 years, but the bone age is less than 2 years. So what is the diagnosis? So bone age, which is very much delayed, height is much more affected than the weight. It is nothing but endocrine. And with features of having a breech delivery, height getting affected after first year, the clinical features of frontal bossing, mid-facial hypoplasia, small hands and feet, it mostly looks like a GHD, which was screened by IGF-1. The IGF-1 was undetectable and was confirmed by a GH stimulation test and an MRI. So these are the other clinical features. They have very cherubic faces here. So they look like doll-like faces. You can have a classic overcrowding of teeth. So this is basically a 12-year-old girl who looks very, very small. She looks like an 8-year-old. And this is like the overcrowding of teeth. This is a case of familial GHD, where the father is also having GHD, missed by everyone. And this is the child who is having GHD who had come to us in CYNOPD. Tushar sir, I think these are your cases.
Yeah, so just a spectrum of GHD and also the severity. So she is 72 centimeters at 3 years. So all of us have been plotting charts. So by now we know that the height at first birthday is around 75, 76. So she's 72 on her third birthday. This particular gentleman is at 7 years is 80 centimeters, and the extreme right is 88 centimeters at 9.5 centimeters. So consider the severity of growth failure, and that severity goes on increasing as the age increases, because they start faltering much below. And as common features, Nikhil has already mentioned that cherubic facies, depressed nasal bridge, and there is apparent hyperthyroidism. We have purposefully hidden the identities, but you can still appreciate that the nasal bridge is depressed. And a word of caution while interpreting growth hormone is never order a random GH test, because it's useless. If you have to, if you suspect strongly that the patient has growth hormone deficiency, take help of your endocrine colleague and plan a GH stimulation testing. Just don't order a random test. Over to you, Nikhil.
Now, what are the history findings suggestive of GHD? So there may or may not be consanguinity. Breech delivery, so 30% of GHDs will give history of breech. There may or may not be neonatal hypoglycemia. The classic GHDs, you will get history of neonatal hypoglycemia, prolonged neonatal jaundice. And there may be central defects like a cleft lip, cleft palate, micropenis, undescended testes, single central incisor, holoprosencephaly. A very, very important point is any case of GHD, never forget to screen the other pituitary hormone deficiencies, and don't be in a hurry to start thyroid hormone. Always rule out cortisol deficiency is there or not. Coming to the fifth case, this is an 8-year-old girl. Height is 110 centimeters. Weight of the child is 26 kilos. So again, to the same question, is the child short? Yes, the child is definitely short. The child's height is less than the 3rd centile, and child's height is way below the mid-parental height. What is the next investigation? We did the bone age. Chronological age is 8 years. Bone age is just 7.5 years. So bone age is not very delayed. On physical examination, so this is the index patient here. This is a younger sib. So she's shorter than a younger sib, as you can see. There is classic wide carrying angle here. And when we looked at the feet, you can see that there is brachydactyly. There is short 3rd, 4th, and 5th metatarsal. And the bone age is showing a classic short 4th and 5th metacarpal. I think by now everyone must have guessed what this is.
Yes.
This is not. Yes. So this is nothing but yeah.
Turner
Please.
syndrome.
Yes. So Turner syndrome confirmed by karyotype. This was a mosaic Turner. Again, like Turner syndrome, like in Down syndrome, we should never forget to screen the other systems. We do a TFT, a 2D echo to look for any aortic abnormalities, hearing assessment, because a lot of these children have conductive or sensorineural hearing loss. USG pelvis to look at any horseshoe kidneys, ovaries and uterus to look at the streak assessment, streak ovaries, and never forget to do pubertal assessment, because only 30% of them enter into puberty and very few of them enter into spontaneous menarche. Majority of them have ovarian failure. So they are going to require hormone replacement therapy later on. So this is when we should be diagnosing a Turner syndrome as early as possible. So this is a child where we picked it up at 1 month of age. You can see that the child just presented with edema at the dorsum of the feet. Before referring to us, a cardiac, liver, as well as the renal system abnormality was ruled out. We just did an FSH in this child. FSH in the mini puberty was very, very elevated, indicating that there is hypergonadotropic hypogonadism, and karyotype confirmed that this is a Turner syndrome. This is a classic 45XO. So as far as possible, diagnose as early as possible. However, patients present to us very, very late. They usually present with short stature and delayed puberty. So there is very less that we can do except offering the hormone replacement therapy. The other classic features as seen here are the webbed neck. You can see a short neck, a low posterior hairline, a lot of nevi. Then you can see levi here again, the short neck. So these are the classic Turner syndrome, but who've been referred or present to us late. So as far as possible, we should avoid a late diagnosis, that is short stature with delayed puberty. Coming to the next case, so this is a 13-year-old girl with short stature, ptosis, and a short neck. So when you have a 13-year-old girl with short stature, ptosis, and a short neck, the first thing that pops up in our mind is this is again Turner syndrome. However, luckily someone had done a 2D echo, and the 2D echo showed that the child had pulmonic stenosis. This is nothing but Noonan syndrome. So yes, Noonan syndrome can also present in girls. The main differentiating feature between Turner syndrome and Noonan syndrome is Turner's is in girl, Noonan can be in either of the sexes. But the 2D echo findings give us a lot of clue. In Turner syndrome, you will have left-sided heart lesions. In Noonan syndrome, you will have right-sided heart lesions. So this is a classic case of Noonan syndrome, and this is the genetic report of the child. Now that we've dealt with the growth disorders, I'll coming to the
So just a quick
yes.
Sorry, Nikhil, just a quick comment because Turner's and Noonan's both are amenable to growth hormone therapy. So it's the duty of a pediatrician to pick them up probably between 4th or 5th or 6th year of life, and then they are amenable to GH therapy. If they receive GH therapy on time, they can achieve a near normal height.
So coming to the next case, this is a 13-year-old boy who comes to the OPD with complaints of small size phallus. This is what the picture looks like. The father and the mother are really worried that this child is having a small size phallus. A very, very common referral in our OPD. So what is the next step in examination? I think the most important examination first is an SMR staging to know what level of puberty it is. So as you can see, the child is having some axillary hair. There is no pubic hair. Testicle volume is 6 ml, 6 ml. So the child has entered into puberty. These are not small size testes. And the stretch benign length is showing that it is around 6 to 6.5 centimeters, which is kind of okay. What is the next important step? I think the next important step is an anthrometry, which would include the BMI. So classically, we have the BMI charts, but again, the latest IIP charts have this BMI tool on the left upper corner of the charts, which is easy. Its plotting is like the weight for height plotting. So for the height, so the child is having 150 centimeters height, the weight is 65. This is nothing but obese. So anything above the red line is obesity. Between the red line and the yellow line is overweight, and below the yellow line is underweight, is normal weight, and below the black line is underweight. So in our child, the child is obese. So a 13-year-old boy with obesity has presented with query micropenis. This is nothing but buried penis due to obesity. What reassures me is that the testicular volume is in puberty. So that is kind of reassuring. And the stretch penile length is also normal. So we just wait and watch and keep observing this boy till he's 14. If the testicular volume is picking up, we don't need to do anything except for weight loss. So this is how we look for the stretch penile length. So we press the pubic pad of fat, and using a wooden spatula or a wooden scale, we measure the length of the penis here. Which cases of micropenis should be worried? So any micropenis which is associated with short stature, so typically seen in growth hormone deficiency, or when the testes are less than 3 ml, even after 14 years of age, or there are associated with undescended testes, as an example of hypogonadotropic hypogonadism, or when the micropenis is associated with some form of hypospadias with or without palpable gonads, which comes under the DSC spectrum. So I think these are the cases of micropenis that we should really be looking for and be worried about. Coming to the next case, this is a 12-year-old child with obesity. Someone evaluated with a thyroid function and labeled it as hypothyroidism. So you can see that the TSH is 6.7, just marginally elevated. Free T4 is normal and free T3 is elevated. Now, is the hypothyroidism causing the obesity, or is the obesity causing the hypothyroidism? That is the question. So did the chicken come first or the egg come first? So no, the hypothyroidism is not causing the obesity here. It is the obesity that is causing the deranged TFT. So we need to understand that a TSH of this much value is not going to cause obesity. It is the fat. So because of the fat or because of the fat, you have increased deiodinase activity. You can have high levels of leptin, which stimulate the formation of pro-TRH, and the inflammatory cytokinins, which are seen in obesity, inhibiting the sodium iodide importer, which all affect your thyroid function test, leading to a marginally increased TSH. So management, do we start on thyroxine? Not at all. The only management here is weight loss. So diet, lifestyle modifications. Automatically, once the child loses the weight, the TFT will normalize and the acanthosis will decrease. Coming to case 9, 12-year-old girl with weight loss since last 2 to 3 months and polyuria. I think whenever we see this, the only thing all of us right now are worried is diabetes, diabetes, diabetes. So as usual, we check the sugar. Sugar was normal. The child had no acidotic breathing. So what are we dealing with? On examination, we noticed that the child presented with a goiter. You can see the goiter here. Heart rate was 110 per minute and there were tremors present. So what is the diagnosis? This is nothing but a case of suspected hyperthyroidism. So how do we diagnose this? We just do a TFT. So we did a free T3, which was very, very elevated. You can see that it was 24.6. Free T4, which was very, very elevated, which was 7.58. And a TSH, which was completely undetectable. Now, how to confirm the diagnosis of hyperthyroidism, whether it is Graves' disease or it's an adenoma, or are we looking at thyroiditis? So either we can do TSH receptor antibody, which is slightly expensive, or directly do nuclear scan. So we directly went ahead with the nuclear scan, which shows an increased uniform uptake, which confirms the diagnosis of Graves' disease. So any child with weight loss, after ruling out systemic causes, please do not forget to do a sugar and a TFT. Coming to case 10, very interesting, and I think all of us in our pediatric endocrine OPDs are seeing this cases very, very, very frequently now. So this is an 8-year-old girl whose weight is 30 kilos, height is 135 centimeters. So now coming to the question, is the child tall or normal? The child is tall because we need to see it in relation to the MPH. So the child is definitely tall for the mid-parental height. So should the parents be worried or not worried at all? Or should the doctor be worried or not worried at all? Is it normal or anything else has to be done? I think any tall child in the pubertal age group, immediately do an SMR examination. Why? Because a lot of our precocious children are going to be tall for the mid-parental height. So on examination, we found that the child had some axillary hair, pubic hair, and stage 2 of breast development, confirming the diagnosis of precocious puberty. I think Tushar sir wants to speak something.
No, please go ahead.
Okay. So now technically everyone will say that precocious puberty should happen before 8 years of age. Our girl is 8 years, 2 months. But the process has started since last 6 months. So in our child, the breast development was seen for 6 months. So the breast development has started when she was around 7 years, 7.5 years. This is followed by axillary and pubic hair since last 3 months. So what type of precocious puberty is this? Is it a central or peripheral? So we do not need test. You can actually just confirm by history. So this is nothing but central precocity. So the normal sequence of puberty appearing early is central precocious puberty. So typically in girls, you will have thelarchy, followed by pubarchy, followed by menarche. So whenever this normal sequence happens before the age of 8 years, it is nothing but central precocious puberty. However, when this sequence is disruptive, when you have a discordance, so like you have thelarchy followed by menarche, or you have pubarchy followed by menarche, it is nothing but peripheral precocity. So in our case, this is an example of central precocity. Is it more common in girls or boys? It is way more common in girls. It has been attributed to certain endocrine disruptor chemicals in the environment which mimic the female hormone estrogen. The most important investigations, as usual, is the bone age. As you can see, the bone age is really very advanced here. The bone age is advanced by around 3.5 to 4 years. As a result, the final height of the child is really being compromised. The child is going to be shorter than the mid-parental height. And the USG pelvis, to look at the size of the uterus, endometrial thickness, and volume of the ovaries, tells us at what stage of puberty and when can we expect the menses to start. What is the most common cause in girls? The most common cause in girls is idiopathic precocious puberty. Around 90 to 95% of cases in girls is idiopathic, no cause has been known. Only in cases which are less than 6 years is when we do an MRI. All girls with precocious puberty do not require an MRI. Only those girls below the age of 6 years require an MRI. This is, I'm talking for central precocity. Any boy with central precocity, MRI is indicated because we need to rule out tumor. In girls, only if they're less than 6 years.
So while ordering the ultrasound, you know, what specific instructions would you like to give? Because
So,
many of the times we get reports like uterus seen normal for age, or ovaries seen. So what you want to tell to the pediatricians?
Typically what I write for the this is, we ask them to mention the uterine dimensions, the endometrial thickness, the fundocervical ratio, as well as the volume of the ovaries. And we've got Indian normative data published by Khadilkar sir in 2007. So we can look at the data.
Perfect.
Other thing I would like to advise all our colleagues is, please do not rely on the bone ages given by the radiologist, because they use a very obsolete Karpal method, which is not at all accurate. We recently published a paper showing which is the most accurate method. So bone age should be done by a person who's trained, or at least try using the Gilson's and Ratib Atlas, which is easily available online. Coming to the next case, again in puberty, it's a 2-year-old girl with
Nikhil sir, easily available on?
Sir, online, sir. Gilson and Ratib is free of cost, sir, online.
Okay.
We just have to type, and the first thing that pops in the Google search result is the Gilson's and Ratib Atlas. Okay. 2-year-old girl with breast development noticed since 6 months. On SMR examination, there was no axillary hair, no pubic hair, stage 2 of breast development, and no menarche. What is the next most important step? Again, I will say it is the growth chart plotting. So you can see the anthropometry. When I plot the height, I realize that the height is within the mid-parental height range. Typically in precocious puberty, you will have tall for MPH. Our child, the height is within the mid-parental height range. Any investigation to be done? We did a bone age. The bone age in a child was corresponding to the chronological age. Chronological age was 2 years. Bone age was just slightly advanced, 2.3 years. Diagnosis: this is nothing but benign thelarchy or premature thelarchy. No further investigations are needed. We just wait and watch and observe. Why we need to observe is because a few percent, around 10 to 15% of the cases can progress to central precocity. So we keep observing. Most of them undergo spontaneous regression. Coming to case 12, 14-year-old boy, average in studies with bilateral chest swelling. So this is the chest swelling, as you can see. What is this? This is nothing but gynecomastia. So how do we feel a gynecomastia? Is when you feel the gynecomastia, you'll get a very rubbery feeling. In obese children, what we typically get is lipomastia, so will be more soft. Gynecomastia will be like the breast tissue will be more rubbery. So it is very important to differentiate between gynecomastia from lipomastia. The next important step in any child with gynecomastia is we do an anthropometry. So we did the anthropometry, and to our surprise, you can see that the child is tall for MPH. A 14-year-old child, a 15-year-old child who's tall for the MPH. We did an SMR examination. So in a 15-year-old boy, I'm expecting almost near normal, near adult-like SMR. However, axillary hair was stage 2, pubic hair was stage 3, and testicular volume was just 8 ml. Adult testicular volume is around 25 ml. So this child had delayed puberty or stalled puberty with a small penile size. Diagnosis, so I'll again recap. This is a 15-year-old boy with whose average in studies presented with gynecomastia. On examination, the child is tall for MPH with delayed puberty or stalled puberty. This is nothing but Klinefelter syndrome confirmed by karyotype. So never forget a tall child who has delayed puberty or stalled puberty with gynecomastia and increased arm span. Always confirm, always rule out Klinefelter syndrome. Now, what is the most common cause of gynecomastia? Well, it is physiological. That is, pubertal gynecomastia is the most common cause. It usually disappears on its own within 2 years. Is pre-pubertal gynecomastia normal? It's never normal. Pre-pubertal gynecomastia is always pathological unless proved otherwise. So whenever you have a pre-pubertal gynecomastia, start evaluating for the thyroid function test, prolactin, look at the liver function test. You might need to rule out a testicular tumor and likewise. Coming to case 13, this is a 3-year-old boy with fracture of femur following trivial trauma. This is the X-ray. You can see that this is a bad fracture here, and this was only by trivial trauma. The child didn't fall from a height or anything. The child just fell down while walking. As usual, we looked for any signs of rickets. There were no rickets. Like a good clinician, we did a calcium, phosphorus, and vitamin D. Everything was normal. So what are we dealing with here? I think before that, we need to ask some important history. So what is the important history we need to ask is any previous fracture history. So in our child, there was 2 previous long bone fractures in the past, again following trivial trauma. Family history is aunt and elder sibling had similar complaints. And on examination, you can see that there are blue sclera. So I think by now everyone has guessed this is nothing but osteogenesis imperfecta, which is confirmed by DEXA, which will show a low bone mineral density. So in children, typically we do only the total body mass, less head, as well as the spine. We don't do the femur in children, and genetics if required to confirm the diagnosis. Okay, so I think I'll ask Tushar sir to chip in here. So now treatment is available for osteogenesis imperfecta. So what is the treatment available? Commonly we use bisphosphonates. And these are the treatment lines, I guess, following bisphosphonate therapy.
Right. So not all OIs have the same severity and same fate. Some of them would have intrauterine fractures also. We have seen newborns, at birth, they have had clavicle fracture or femur fracture, and often the OBGY, poor OBGYs are blamed for those fractures, but many of them have actually the severest forms. And not all OIs do have that blue eyes. So there are certain OIs that do not have blue eyes. So although we should look, all the picture together, and plus DEXA, as correctly mentioned by Dr. Nikhil, these lines that you can see on the X-ray, you can actually count those lines. They are parallel to the epiphysis, and these are called as zebra lines. The moment you start giving bisphosphonate injections like zoledronic acid or palmitonate, so these drugs, they kind of go and deposit in the bone and cause a denser line on the bones, because the osteoclasts they are suppressed, and the osteoblast would give rise to a thicker bone, and these lines correspond to the injections that are given. So you can actually count those lines and know how many injections the child has received, and these are called as zebra lines.
I'll just like to add one more thing.
Yeah.
Similar lines, if we see in a child with short stature, so they will be slightly higher. I think this was first reported by Kardilkar sir only. These are nothing but called as the metaphyseal growth arrest lines. So commonly seen in psychosomatic short stature or where you have dysfunctional families. So if you see a child with short stature, when you do the bone age and you see some lines like this slightly above, agree in the metaphysis, then please suspect something like a psychosomatic or a dysfunctional family. That could be the reason of short stature.
Yeah.
Coming to case 14, again back to growth, my favorite topic. 6-year-old boy born of LSCS, 1.7 kilos, full term. As we look on the growth chart, at 6 years, the child's height is around 101 centimeters. Weight of the child is 20 kilos. So as usual, is the child short? Yes, the child is short because the height is less than the third centile. Child is short for the MPH. On clinical examination, there are subtle clues which the child is telling us, So this child is having clinodectally, very mild, but there is clinodectally. There is limb asymmetry. If we closely look, that this limb is slightly below than this limb, and the child is having facial asymmetry. Most important investigation, as usual, is bone age. So in this, the bone age is actually slightly advanced. So the child is 6 years, the bone age is 7 years. So we did a baseline workup, all tests like CBC, creatinine, and TFT is normal. So what is the diagnosis? So this is nothing but an SGA child who's failed to catch up. So if you remember, the weight of the child was 1.7 kilos. At 4 years, the child is not caught up. So this is nothing but an SGA child who fails to catch up. Till what age should we wait for catch-up growth? So catch-up growth is that you should reach either the third centile or the mid-parental height, whichever is higher. So our child has not reached both by 4 years of age. So by 4 years of age, every SGA child should have achieved catch-up growth. And what is the treatment? Since last 20 years now, growth hormone is a licensed indication for SGA children who fail to catch up. So any child SGA who's failed to catch up at 4 years of age should be given growth hormone therapy. Case number 15, 15-year-old boy, 15-year-old born SGA, previous history of premature adenorrhea, menarche at 12 years. Now irregular cycle since last 2 years, coming every 2 months. I think with the rampant increase of obesity, a lot of us are seeing this, a lot of acanthosis. So the child has severe acanthosis, the child is hirsute, there is hair present on the upper lip, on the chin, on the upper chest, and the child is obese. So an obese child with acanthosis, hirsutism, and irregular cycles. What is the diagnosis? This is nothing but PCOS. Criteria of PCOS. Now the PCOS criteria have become very, very simple. It's entirely a clinical criteria. It is irregular menses and hyperandrogenism. So hyperandrogenism could be in the form of severe acne or hirsutism or elevated testosterone levels. Should sonography be used to diagnose PCOD in adolescents? Never, because polycystic pattern can be seen in normal adolescents also. So we should never do a sonography unless we are suspecting something else. But for PCOD per se, clinical diagnosis is more than enough. The maximum we can ask is for a testosterone. How do we define irregular menses? Up to 1 year of age, any form of irregularity is normal. Between 1 to 3 years, anything less than 21 days or greater than 45 days. Greater than 3 years, anything less than 8 cycles per year is abnormal. I think that is the easiest for the patients to remember. And greater than 1 year, if the cycles are coming at 90 days intervals, that is also abnormal. Primary amenorrhea by 15 years or 3 years post-thylarchy. Treatment in such cases, like any child with obesity, lifestyle modifications, OC pills will be warranted, plus minus metformin and plus minus spironolactone for the hirsutism. Last 2 cases. So 7-day-old child now admitted with seizures. Like any good neonatologist will do, check the sugar first. The sugar was normal. They checked the calcium. Calcium was 5.5. Now, what should be your next step? I think the most important thing is please send a critical sample. We should send a calcium, phosphorus, albumin, PTH, vitamin D, and alkaline phosphatase, and then treat with IV calcium. Please do not be in a hurry to start IV calcium. Please send the samples first. Same advice will be for any case of hypoglycemia, for any case of adrenal insufficiency. That critical sample is a must. Treatment can be delayed by a minute or 2, because if the treatment is given, interpreting the test becomes very difficult. So we send the samples and these are the reports. Total calcium of 5.5, phosphorus of 8.8, vitamin D of 24, albumin and alkaline phosphatase normal, and PTH of 21. So how do we interpret this? So this is nothing but hypocalcemia, hyperphosphatemia, and vitamin D is normal. However, if you look at the PTH might look normal if you look at the range, but for the amount of low calcium, you expect the PTH to be much higher. So this is an inappropriately low PTH for the hypocalcemia. So this is nothing but hypoparathyroidism. So when you have an inappropriately low PTH with hypocalcemia and hyperphosphatemia, it is nothing but hypoparathyroidism. It is usually transient in the newborn. However, if the same case had persistent hypocalcemia, that is persistent hypoparathyroidism, some dysmorphic features, some heart defect on the 2D echo, and absent thymus on the X-ray, please do not forget that this is Diagnose syndrome. Coming with my last case now, 6-year-old boy with subnormal intelligence, birth weight being 2.1 kilos, admitted with seizures. Total calcium was 6 milligram per DL. As usual, no other workup was done, treated with IV calcium, given loads of vitamin D, and then discharged on oral calcium. The child was readmitted after 2 months with hypocalcemic seizures. So on examination, the pictures are not very clear, sorry for that, but you can see that this is the knuckle dimple sign. So because the short 4th metacarpal here and the short 4th and 5th metacarpal, you can see that the 1st and the 2nd knuckles are well appreciated. The 3rd and 4th are not so well appreciated. And there is some form of brachydactyly. We did the test. Calcium was 6.45. Phosphorus is 9.05. PTH is 798. The range is 15 to 65. And vitamin D is 60.38. So how do I interpret this? This is hypocalcemia, hyperphosphatemia, and normal vitamin D, and high PTH. So there is some form of hyperparathyroidism that is happening despite the normal vitamin D. So this is not secondary hyperparathyroidism. Can it be primary hyperparathyroidism? No, it cannot, because primary hyperparathyroidism will have hypercalcemia and hypophosphatemia. So what is this? This is nothing but PTH resistance or pseudohypoparathyroidism. So typically what will happen is you have a picture like hypoparathyroidism. So you have a low calcium and an elevated phosphorus. But because the PTH is not working properly, the PTH will be very, very elevated. They typically have short stature, obese, round face, the classic AHO phenotype. They can be born SGA. They might have subnormal intelligence, brachydactyly, and ectopic calcification.
Thank you, Nikhil. In last out of 17 cases, I think you shown growth chart in 15 of them. And it stresses correctly the importance of it clearly tells us that all pediatricians should start plotting the growth charts if they are not doing it already. The last case, I hope my slides are visible. The same PPT I am continuing now. Are the slides visible? Slides?
You started sharing.
Yes, sir.
Yes.
Yeah. So we have so many calcium preparations in the market, and we have been bombarded with various combinations of vitamin D and Rocaltrol and magnesium and vitamin K, and all those medical representatives come to us and tell us that isse calcium itna guna badhta hai, and many of the times we end up using very costly brands that has calcitriol in it. So calcitriol is the active form of vitamin D that generally we don't need it. It's an extremely dangerous drug. If you keep on giving it, it can actually cause hypercalcemia, life-threatening high calcium, also nephrocalcinosis. But the last two cases that Dr. Nikhil showed are the real indications where one has to use Rocaltrol or the calcitriol, the preparation that is the active vitamin D. Other than that, for routine vitamin D deficiency or as a calcium supplement, one must refrain from using preparations that have calcitriol because it's a potentially dangerous drug. So now I'm starting my part of the presentation. So we have had a lot of discussion on growth charts, and we enough has been told that every case, be it short stature or anything, one has to take the anthropometry plot the growth chart, and interpret the anthropometry accordingly. So that everything is already taken into consideration. Now, in addition to that, what pictorial things we must pick up as clinicians. So in addition to growth charts, I'm going to present a few cases. Most of them are pictorial, and at the end of every case we have a take-home message. So this is a 10-year-old male child coming to you with 115 centimeters of height and 30 kilograms of weight. So by now you are familiar with the growth charts. So he's on 10th birthday. He's quite short, and also for his height the weight seems to be inappropriately more. So he's short and obese child. Nikhil has shown us that on growth chart, if you find a short and obese child, one must think of three possibilities. Either this could be endocrine possibility is the first one, and amongst endocrine you could have either hypothyroidism or growth hormone deficiency as a part of hypopituitarism, or the last one that Nikhil showed was a pseudo hypopara, where these are also the children that are short and obese. But here we have a clinical clue, and that is prominent calf muscles with muscle weakness. So the muscles are like a footballer, but they are weak, and there is a pendular knee jerk or a knee jerk with delayed relaxation. That's a more appropriate description. So what is the diagnosis we have here? What is the diagnosis that we have here? So this is called as Cocker-Debré-Semelin syndrome. This is so we have a short child with obesity relatively, and you can see the dry skin, and this is the pseudo hypertrophy of the calf muscles, also called as Cocker-Debré-Semelin syndrome. It is seen in long-standing untreated hypothyroid. So it's a clinical clue in long-standing cases, and we hope and believe that after listening to Nikhil's part of the talk, we will not see such kind of cases, because we will be plotting these on growth charts and picking them up much before this syndrome develops. And in these cases, the CPK will be elevated, but the CPK elevation in your Duchenne's muscular dystrophy or other kind of muscular dystrophies or real muscle disorders is in thousands, whereas the CPK elevation in this condition is marginally elevated in hundreds. This is a 4-year-old male child coming to you with acne, increased phallic length, and there are pubic hair that are present. Now, this is the orchidometer that we were talking about a few slides ago, and this is a handy tool that a pediatrician should be carrying in their OPD. So here we have a 4-year-old child with acne. Now, acne are present in two age groups. First is the neonate, where we have acne neonatarum, and the other one is during the 3rd or 4th stage of puberty, where there is a lot of androgen getting formed. But why is this 4-year-old male developing into acne? So acne marking the androgen excess, and this particular child who is 4-year-old, where is the testosterone coming from? So in particular, a case where Nikhil showed that on growth chart, we diagnosed this child to be having accelerated growth, and we suspected him to be having precautious puberty, and we then checked his genital growth. So on genital examination, this child has got a testicular volume of just 2 to 3 ml. And we know that the testicles don't produce enough testosterone until they cross a volume of 4 ml or 5 ml. So since the testicles are small and the child is virilized, meaning he is having a lot of androgen. So where is the androgen coming from? So this is a typical case of pseudo precautious puberty. The testicles are not forming testosterone, but it is coming from the second organ, and that is adrenal glands. So here is the adrenal androgen pouring into the systemic circulation, and that is giving rise to this. So acne are abnormal in a 4-year-old. Testicular volume 4 ml is the first sign of puberty, and here it's just 2 ml. So he in addition had dark complexion as compared to the parents, and we did 17-hydroxyprogesterone as a screening tool. All of us know that CAH can come like salt wasting crisis in a newborn, but these are not the salt wasting ones. These are called as the simple virilizing CAH typically come between the age groups of 3 years, 4 years, 5 years with virilization. And a diligent pediatrician would pick up these children on a growth chart and also examination of the testicles. He is
So
an
just like
8.
to add
Sure.
just 1 minute, sorry.
Sure.
So as Sir just said, ki any again I'll be reiterating here ki any concordant puberty is central precocious puberty. Here it is discordant. So there was no testicular enlargement, but there was a penile enlargement. So this is discordant. This is peripheral precocity. And one more point I'd like to add is, in rarely, if there is a very rapid onset of virilization, please get a USG abdomen also done, because recently we saw a case with adrenal mass.
Absolutely.
So that is another thing. Yes.
Correct. So if you have, so we have been taught that if you have a short and obese child, then think of Cushing syndrome or
Yes.
endocrine causes. And if we have a tall child with obesity, then generally it is lifestyle related. But this is one such example where if you have a mixed hormone secreting tumor from adrenals, there the children are tall as well as obese. So thank you, Nikhil, for mentioning that point. So we have 8-year-old male child has had 2 seizures, both of them in the morning time, required admissions and IV fluid, and with trivial, some viral fever or some 1 or 2 vomitings, the child becomes extremely sick. And the moment he receives IV fluid, dextrose containing or some DNS, the moment he receives IV fluid, within 15 to 30 minutes, the child becomes absolutely normal. And in the evening, he is discharged. And again, with some illness, he again has similar hospitalization. And there has been no weight gain over last 1 year. There is pigmentation over the gums and knuckles. So I think most of you have already picked up the diagnosis as Addison's disease. Yes, this is adrenal insufficiency, and there are multiple causes, and one has to dip into the etiology, because the etiology would have implications on the future management and also the comorbidities. So Addison's disease, the pointers for a pediatrician are lack of weight gain, pigmentation, hypoglycemic seizures, typically in the morning time. Pigmentation is due to elevated ACTH, and glucocorticoid and mineralocorticoid axis have to be evaluated and replenished if required. And etiology is extremely important for the prognostication. Please remember, these are the cases that would be following up with the endocrinologists, but the pediatrician has to be aware of these conditions, because if an Addison's disease patient on treatment is vaccinated for his DPT booster, the pediatrician has to be aware that for that DPT booster, which is going to have a lot of fever because of the vaccine, this is the child that is going to crash after vaccination unless you give them something called as stress dosing. So if your patient is having adrenal disorder and is under treatment with some endocrinologist, please tell them that vaccine ke baad mein fever aayega, and for fever you have to give extra dose of your steroid or hydrocortisone. Similarly, it's also important for the pediatrician to know that Addison's disease, if there is any surgery required, be it a circumcision, be it undescended testis surgery, be it some any trivial surgery, please take help of your endocrine colleague and plan the peri-operative steroid management. Otherwise, you might have a problem on table. So this is a 3-year-old girl coming to you with fever of unknown origin, and she has had weight loss of 2 kilograms. She also has excessive sweating with tachycardia. The 2D echo is normal, and she has prominent eyes. Any clues here? So we have prominent eyes. It seems like the girl is staring at us, and she has excessive. Absolutely correct. So Dr. Nikhil had shown one case of Graves' disease where she was an adolescent girl with a goiter and tremors and tachycardia, everything. But the point I wanted to make here is Graves' disease can come as early as 2 years or 3 years, and these are the girls that may or may not have a prominent goiter, but the constant feature is tachycardia, weight loss, excessive sweating, and they can have presentation as pyrexia of unknown origin. So as a part of your PUO workup, please remember to check the thyroid profile. So this is called as Graves' orbitopathy. It can happen before your thyrotoxicosis phase or after your thyrotoxicosis phase, and it's important to remember thyroid. This is 8-year-old boy normal growth and development. He is born of a 3rd degree consanguinity, and he has had these skin lesions starting from 2nd birthday, and he has been seen by a dermatologist and then referred to an endocrinologist. What is the diagnosis here? So these are called as xanthomas, and these xanthomas depict a lipid handling defect. These xanthomas are actually the deposition of your LDL cholesterol underneath the skin, typically seen on the extensor surfaces and the joints. The typical lesions are seen on the knee joints, on the hands, the elbows, the buttocks, and the tendo Achilles. So this is the lipid profile of this particular child with an cholesterol that is beyond measuring capacity of the particular lab. So here the report is given as above 705, and the LDL here we measure by a method called as a direct LDL, where it's not calculated one but the direct one. And this particular child, we sent his mutation and found to be having a homozygous mutation in the LDL receptor. And this is an extremely difficult case to treat, and these children often succumb to cardiac event or stroke in their 2nd year of life. So important to pick them up early and treat them. Some of them do get benefited with liver transplant, but most of them would be needing anti-lipid agents as statins and ezetimibe. So these are called as xanthomas, and skin biopsy is not required. Please remember, these are the children that will be subjected to skin biopsies unnecessarily, and these are treated with dietary measures, statins, and some antibodies like ezetimibe. And if it doesn't help, then probably plasmapheresis is one treatment, or liver transplant is the ultimate treatment for homozygous, the severest forms.
I'd just like to say one point.
Sure.
Just never forget to screen the siblings here, because it's quite possible the other sibling might be having the same condition. And always, if possible, get a carotid Doppler done, because you might see that the arteries might be blocked. So as Sir said, they do succumb because of cardiac abnormalities. So 2D echo and a carotid Doppler should be done, I think, in these cases.
Absolutely. Absolutely. So this is an infantile onset obesity. The child has come to you. Parents are anxious. They say, lockdown में मेरा बच्चा मोटा हो गया है, सबके बच्चे मोटे हो गए हैं. But the clinical clue here is infantile onset obesity with post-axial polydactyly. So the polydactyly is on the little toe side, not the greater toe side. The child also has photophobia and poor vision. At night, the child, fumbles and bumps into objects. So, and this is the fundus examination of the same child. So what is the diagnosis here? I think most of you have got it correct. This is Lawrence Moon Bardet Biedl syndrome, LMBB syndrome. So the common features in LMBB syndrome are infantile onset obesity with subnormal intelligence. The photophobia may start as early as 1st birthday, and many of them become visually dependent by their end of 1st decade, and they have the type 2 diabetes and pulmonary hypertension and cardiac all those cardiac events happening in their 2nd year of life. They need aggressive dietary management, and despite doing everything correctly, they might actually still need bariatric surgery or some drugs like centrally acting GLP-1 analogs. And those are the set of drugs that might help, but eventually the prognosis is not good. The other common syndromes are Parabola syndrome and Alstom syndrome that begin right from the infancy or early childhood. So this is one such example where she is a girl that came to me in her early childhood, but this was the photograph in her infancy, where in infancy she was being treated with all kind of appetite stimulant drugs. बच्ची खाती ही नहीं है, and she was failing to thrive until the 1st birthday, and beyond 1st birthday she rapidly started to gain a lot of weight. She has got significant speech delay and little bit inappropriate behavior, and she has bitemporal hollowing, typical almond shaped eyes, short stubby fingers, and this is another form of a common syndromic obesity, and that is, yes, most of you have got it correct. This is Prader-Willi syndrome. It's a common genetic disorder with obesity as a part. So what are the clinical clues towards syndromic obesity? Is most of them have early onset obesity. They have a voracious appetite, and the parents sometimes have to lock their kitchen or the refrigerator, because in the night they will just crawl into the kitchen and eat whatever is present. They never feel satiated. They can have a full meal, and within 15 or 20 minutes after their meal, they can again ask for food. The common clinical clues are hemihypertrophy, or red hair, or macroglossia, bitemporal hollowing, polydactyly, umbilical hernia, squint, maybe photophobia with retinitis pigmentosa, developmental delay, and a true hypogonadism, not the kind of hypogonadism Dr. Nikhil showed, that's the buried penis, but here we have a true hypogonadism. These are the clinical clues towards syndromic, part of obesity. And here you need definite help of an endocrinologist as well as a clinical geneticist. This is a 10-month-old male child, 67 centimeters and 10 kgs. So he is again short and obese. He has excessive facial hair and plethoric moon-like facies with hypotonia and motor delay. So what is the diagnosis here? Yes, so he has definite moon-like facies. So this is something endocrine going on. And since he has plethoric facies with excessive hair, probably we are dealing with something to do with the adrenal glands. So now further history here we have to ask, has the parent been giving some drugs? So here some cream was being given for a nappy rash, or in other cases we have seen that they give some over-the-counter drugs like Dexona drops or Decadron drops for a normal cough and cold. And these steroids, be it oral in oral form or inhaled form or topical form, if potent steroids are given for longer durations, these cause exogenous Cushing's, and that's by far the commonest cause of Cushing's syndrome in children. And these are the children who cannot be stopped of their steroids suddenly. If you suddenly stop the steroid, they will crash. So a gradual tapering is required. So you stop the offending drug, but at the same time, you give them a physiological dose of hydrocortisone, and then start gradual tapering from thrice a day to twice a day to once a day, then make it alternate days, and then check their 8 a.m. cortisol. So this is what exactly we did for the child. We slowly tapered the hydrocortisone, and this is how wonderfully the obesity went away. The child's myopathy or the muscle weakness also improved, and the child's height the length started to normalize. This is a 4-year-old male came to the pediatrician with snoring. So typical snoring at night. The growth and development is absolutely okay. The ENT got involved, and the ENT evaluated that there was a mass sitting at the base of the tongue. Now, what is going wrong here? So this is a very common scenario. I'm sure most of you have had such cases. And by mistake, if the ENT surgeon or the pediatrician is not aware of the condition, some biopsies would be performed and some unnecessary surgeries might be performed. So here a simple clinical test, and that is palpation of the thyroid gland at here at the thyroid fossa, or just below the cricothyroid is required. If you can palpate the gland there, then you can go ahead with the planned surgery or whatever. But if you can palpate the bare trachea, so the trachea rings, if they are easily palpated throughout, then you probably have absent thyroid gland in the neck, and the same thyroid gland is sitting at the base of the tongue, and this is called as ectopic lingual thyroid gland. Most often they do not require any surgical management. All they require is just supplementation with thyroid. So this is a lingual thyroid. All that you have to do is just supplement them with thyroid, and it would just revert back. So this is the thyroid scan of the same patient, showing that the thyroid is absent in the neck, and the same thyroid is sitting in the tongue. The moment you start treating them with levothyroxine, the TSH that is elevated, marginally elevated, it will start suppressing, and the gland that is swollen in size will slowly come back to normal size, and the snoring and the obstructive symptoms would go away. If you have persistence of those snoring and obstructive symptoms despite correction of thyroid, then one might have to think of some corrective procedure for the obstructive sleep apnea. I think last 3 or 4 cases we have. He is a 7-year-old with 94 centimeters height and 12 kilos of weight, extremely short as well as failing to thrive. So he has short stature as well as underweight. So as Dr. Nikhil has told us, when you have weight affected more than the height, think of systemic causes, and he has progressive knee deformity since notice since 1.5 years of age. He has primary nocturnal enuresis, so that's our clinical clue. He is born with 3rd-degree consanguinity, has mild motor delay, and his creatinine is normal, electrolytes are normal. So we have reasonably ruled out renal failure at least. So what is the diagnosis here? So he has rickets.
Renal tubular disorder.
Absolutely correct. Absolutely correct. So this is a renal tubular disorder, the congenital one, not an acquired one, because we have a consanguineous marriage and the onset is right from the infancy. Here the alkaline phosphatase is 704 with phosphorus slightly on the lower side. Calcium is also on the lower side. 25 hydroxy vitamin D is normal. So we went ahead and did his venous blood gas, and that turned out to be acidotic with a pH of 7.2, bicarbonate of 14.6, and base excess of -12. And the ultrasound showed loss of corticomedullary differentiation, but there was no nephrocalcinosis. So this is renal tubular acidosis type 2, or also called as the proximal renal tubular acidosis. In proximal RTA, you can have loss of phosphorus as well as your bicarbonate, and some of them do have hypokalemia as well. So but every case is different. They can have a varying severity. So this particular patient was started on sodamint and potassium replacement, and the follow-up after 1 month showed a normal pH and normal bicarb, and after 9 months he gained around 10 centimeters, 8 to 10 centimeters of height and 2 to 3 kilos of weight, and the polyuria was improved. So merely by correction of your potassium, merely by correction of your pH, the polyuria gets subsided and the child starts to grow wonderfully. And this is how on a growth chart the child is showing improvement. And after 1.5 years of treatment without surgery, the deformity got corrected. I was invited in an orthopedic conference, and when I showed this this image, next time they stopped calling me for for their conference. So not every knee deformity requires surgery. Most of them, if you diagnose them on time and correct them on time, you can get away without a surgery. But the crux is a right diagnosis and a right treatment. This is Jay sir's favorite case. Jay sir, ऐकता है ना?
ऐकतो.
8-day-old male child admitted with lethargy, poor feeding, and unusually dark skin. There are no ambiguous genitalia. The child was actually presented in shock and peripheral pulses were feeble. I have straight away given you the crux or the clue findings, that is hypoglycemia. Electrolytes were 129 and potassium was 6.8. But this story was not that simple. The child was admitted with sepsis, presumed sepsis, was on multiple antibiotics, and he kept on deteriorating. He also had hyperbilirubinemia, so phototherapy was also being given, and the dark complexion was actually attributed to phototherapy. So the diagnosis was actually much delayed, and when multiple samplings were done and as a part of follow-up, the electrolytes were repeated, and that time the diagnosis was clinched on that low sodium and relatively high potassium. So by now I think most of you have correctly diagnosed. This is adrenal crisis with salt wasting crisis in a CAH, congenital adrenal hyperplasia. So this is a male child coming to us with adrenal crisis. So all of you are aware that 21 hydroxylase is the most common form of CAH, and the salt wasting variety in a male will have no ambiguous genitalia. Had this been a female child, you would have diagnosed right at birth because of the ambiguous genitalia. So males, here in it's often said that males are always the sufferers, and here also in this particular case, because of delayed diagnosis, many of the newborns actually succumb because they are not picked up on time. So 17-OHP is the test that you should be ordering. And as soon as you have collected the sample for 17-OHP, you should give them a full strength DNS without potassium and a dose of hydrocortisone. At many places, including Nashik, we don't get the 17-OHP within 2 to 3 hours. It may take 8 hours, so sometimes the report is available on the next day. So don't wait for the report. Just if you have collected the sample and if you have a strong doubt, just give hydrocortisone and then call up your endocrinologist for further management. The take-home message is male CAH comes without ambiguous genitalia, and they can directly go to shock, and sepsis is often blamed. But then if you have CRP that is not very much raised, and if you have pointers like low sodium, high potassium, please think of a male CAH. I think this is second last slide, probably, or third last. 7-year-old male child, morning time hypoglycemia, again, progressive darkening of the skin. He has swallowing difficulty. Now, adrenal failure, you have all made the diagnosis here because that pigmentation you have picked up, the nails and the gums and lips are black. But here is an additional clue, and that is difficulty in swallowing solids. And as you pricked the child to collect samples, he made crying sounds, but there were no tears. Magarmach ke aasu bhi nahi the. So this is the child is crying without tears and is having difficulty in swallowing bhakri or any solids. So here we have a particular syndrome, that achalasia, alacrimia, and Addison's disease, also called as AAA syndrome, also called as Algroove's syndrome. So why should I bother about this? First is it is amenable to a simple surgical procedure where the achalasia can be corrected. And secondly, some of them do not require mineralocorticoid. Generally Addison's disease madhe, we give glucocorticoid as well as mineralocorticoid, that's Hyson as well as Floricort. But if you make a correct diagnosis, this patient usually does not need fludrocortisone. Most of them do very well on hydrocortisone alone. So neonate in adrenal insufficiency, in neonate think of CAH or sepsis. In childhood think of a familial glucocorticoid deficiency or Algrove syndrome. And in adolescents or late childhood or early adolescent think of X-linked adrenoleukodystrophy, particularly in males. 8-year-old male child, a known case of type 1 diabetes since age 6. He has low insulin requirement as compared to your other children. So for example, a 30-kilo child would require insulin of 25 to 30 units, but he requires a very low dose of around 10 units or 12 units. So his insulin requirements are actually low. He has a preserved C-peptide, that is the beta cell mass, and GAD antibody was negative. And he has excellent sugar control. Sometimes he goes into hypoglycemia, but the polyuria is continuous. So despite good sugar control, the polyuria is there, and he has vision problems. So that's why you got his eye checkup, and he has high index myopia with optic atrophy. So here we have polyuria with diabetes mellitus and optic atrophy. So does it ring any bells? So this is a combination of diabetes insipidus with diabetes mellitus with optic atrophy and deafness. So all of us would ring bells here, but the poor child would not hear that ringing bell because he has deafness. So this is called as Wolfram syndrome, also called as a Didmore syndrome. It's not uncommon to have, but a high index of suspicion should be kept if you have low insulin requirement and a polyuria. He's again 8-year-old male child, has multiple episodes of carpopedal spasms. Dr. Nikhil has taught us to collect the critical sample. So the PTH was collected. The PTH was collected, transported properly in ice, barfa madhe, and then the PTH was processed and it was undetectable. So here we have a low calcium with low PTH. So the diagnosis here is hypoparathyroid, like Dr. Nikhil showed us. But here we have additional clinical clues, and that is vitiligo, oral candidiasis, loss of eyebrows, that is called as the madarosis, and he also has hypothyroidism. So here we have a syndrome with multiple autoimmune conditions coming together, and this is called as autoimmune polyendocrinopathy syndrome. And this particular case is called as Apsed syndrome, where you have a combination of hypoparathyroid, hypothyroidism, candidiasis, and ectodermal dysplasia. So one has to keep in mind that if you have one autoimmune condition, the other autoimmune conditions can also come together, like your type 1 diabetic patient can have celiac disease or thyroid together. So this is, I think, my last case. This is 5-month-old male child, came to us with delayed milestones, umbilical hernia, hoarse cry, constipation. What is the diagnosis here? Is everyone happy diagnosing this child at 5 months? Hypothyroidism congenital 1. Yes, that is the diagnosis. पण त्या डेथ सर्टिफिकेट मध्ये असतं ना cause A, cause B, cause C, तसं the immediate diagnosis is congenital hypothyroid, but the latent diagnosis is the birth was attended by the pediatrician, but the pediatrician failed to write neonatal screening, TSH लिहायला विसरले. And as a result, the thyroid was not checked and the patient was diagnosed very late on the 5th month. And here we have missed a diagnosis of congenital hypothyroid. So this is, medical negligence. If tomorrow this case happens and this parent goes to the court, then it will be very difficult for us to, all of us to defend ourselves, because now Indian Society for Pediatric and Adolescent Endocrinology, ISPE, as well as IAP, all of us are, recommending universal thyroid screening for every live born child. You must write on paper and, tell them that your child needs thyroid screening. Whether they do it or not is totally their decision. But as a pediatrician or a neonatologist, I must recommend TSH to all of them. So this is the spectrum of neonatal or congenital hypothyroid. Most of them are asymptomatic. Some of them would come to you with protruding tongue, jaundice. Some of them would come to you with hoarse cry. This particular is infant that is sick and umbilical hernia. This particular child is 8-year-old child with waddling gait and mental retardation. And this particular child, you can see 10-year-old boy, deaf and mute. And this young boy is 22-year-old with missed case of congenital hypothyroid. And this is a 25-year-old lady with congenital hypothyroid, never picked up. So at least after listening to the talk by both of us, we should start screening, because this is one congenital hypothyroid that's one of the preventable cause of mental retardation. So please start checking TSH for all your newborn. When to check? Either cord blood or after 72 hours of life. Cord blood or 72 hours of life, not in between. And the cutoffs, you can see this ISPAA 2017 recommendation. This is freely downloadable. You can download these recommendations. The cutoffs to remember is 20 cutoff up to 2nd week of life, and beyond that the cutoff for TSH is 10. I'll not spend much time because you can actually go and visit these recommendations. Thank you, Dr. Jai. Thank you, Dr. Samir. Thank you, Gangolia sir, for giving both of us this opportunity. These are our email addresses, Nikhil and me. Thank you. Thank you so much.
Wow. What an excellent presentation. Rather, we thank you, Dr. Tushar and Nikhil, for this. म्हणजे नाही, आपण तुम्ही कसोटीवर खरे उतरलात असं मी म्हणेल की जे डोक्यात होतं की एंडोक्राइन पल्स दॅट रिअल पल्स आय कॅन से, बिकॉज ऑलिम्पिक्स अटेंडन्स शेवटपर्यंत व्यवस्थित आहे, अगदी व्यवस्थित. पीपल आर स्टील सिनियर आर लिसनिंग टू दिस, अँड आय एम व्हेरी ग्रेटफुल फ्रॉम द बॉटम हार्ट फ्रॉम द महाएपी पीपल, राईट. यू प्रेझेंटेड व्हेरी वेल. जे स्पेक्ट्रम पाहिजे अगदी तसाच होता. धन्यवाद. थँक्यू. समीर, ओव्हर टू यू. काही क्वेश्चन्स आहेत का? घ्या. अनम्यूट. Unmute. समीर अनम्यूट करा. अनम्यूट युअरसेल्फ.
पल्लवी मॅडम, समीर अनम्यूट करता येत नाही, बघा जरा.
मॅडम आहेत का?
हो आहेत ना. पल्लवी मॅडम, अलाव डॉक्टर समीर टू. थांब ना, मी करतो, थांब ना.
पहिले काय करता?
Okay, so now yes, is now on mute. So मुझे ऐसा लग रहा था कि we should not stop. There should be not another 20 cases more, because some I can able to diagnose immediately, some I could not able to diagnose. So I was just thinking क्या हो सकता है, something like that way. And some of the friends were actually playing with each other. It's like, who is going to tell first answer? Like suppose congenital heteroplasia, I said congenital heteroplasia. Somebody else messages that it is the additional feed. It is 17 hydroxylase deficiency or like whatever different, like apart from the things. So it was very nice by Tushar and Nikhil both. I have one question for each of you. Dr. Nikhil, first question is like, suppose you want to say growth hormone to give, but what is the ideal age to diagnose it by the pediatrician? Because most of the times we never diagnose them at least up to 7-8 years of age. When parents come that height nahi badh rahi hai. That is that way they speak. And some people may come, or children may come presentation by 12 or 13 years, and we say, oh, it is very sad, we come late. So what is the ideal age you feel that it should be diagnosed?
As early as possible, sir. That is the best, because the earlier we start treatment, the better, because the better effect we'll get of growth hormone. Plus, at an earlier age, the weight is less, the cost of growth hormone will be less. So we can do that also. So as early as possible would be the clue, but there is no specific age cutoff, but as early as possible. That's what I would say.
Like suppose somebody comes by 13, 14 years, like what your advice will be for those days?
Depending on the bone age, sir, if the bone age is showing, which will definitely be delayed, growth hormone can be offered, but then they will have lost out many years of height on that. So there will be some response, but not the optimal response that we want.
What I heard, before 5 years start, before 5 years, they have a very good chance to attain the best potential.
Yeah.
I have heard in the talk.
Yes. So whenever we are not, yeah. So what happens is, for a general pediatrician, we are not yet sure whether this is growth hormone deficiency, and if the parents are also short, and there is a lot of realigning happening. Na? So they go to their genetic potential. So first couple of years, definitely we would like to wait unless the patient has, life-threatening hypoglycemias as a result of GH deficiency. And there we have started GH as early as first birthday. But I agree with Nikhil that probably between, not later than fourth birthday, but as early as possible. Yeah.
Dr. Tushar, one more thing was there for you actually to ask now.
Yes,
about the treatment of rickets. Like suppose I heard many times, like somebody gives 60,000 units, somebody gives 3 lakhs units, someone gives 5,000 per day. Somebody now says nowadays it's better to give only 2,000. And somebody says rocatrol. That is the different ways people feel. And you definitely mentioned that rocatrol should not be used. So what is the actual regime you feel we should do?
Yeah.
And second question will be with that. Will you do only vitamin D levels? You will do vitamin D, 25 hydroxylase as well as 125 levels. Or you can also ask for calcium, phosphorus, and alkaline phosphatase also along with this.
Right. So the latest recommendations were out in just, I think, 4 or 5 months ago. I think December 2021 or January 22, the IAP vitamin D deficiency guidelines, they were published. And even the previous ones, 2017 as well as 22, both the guidelines reiterate the fact that one should refrain from giving mega doses. So 3 lakh unit, 6 lakh unit to nahi dena hai. That's for sure. Now, the daily dosing is better in terms of avoiding toxicity and giving a sustained delivery. So worldwide now it is accepted that giving a daily dose for 90 days is a better idea, because it does not cause a lot of fluctuations in the levels. It gives a sustained delivery. So what we prefer is 2,000 international units per day for a child below 1 year and 3,000 international units per day for a child above 1 year to be given for 90 days for a plain simple vitamin D deficiency or rickets. And along with that, you give calcium. Now, if compliance is an issue, कारण ते 2000-3000 देणार कसं? So 3000 द्यायला तुमचं 800 वाला preparation, so you'll have to give some 4 ml every day, and then compliance is a big issue. So there is an option, of course, that you could give 60,000 international units per week as 4 to 6 weeks, depending on the age again, but definitely not 8 or 10 or 12 doses that previously we used to give. I remember my thesis was on vitamin D in 2008 to 2010, where I've injected 6 lakh unit in 90 children, and now I feel guilty that I have done that, but that time those guidelines were not there, so now I'm safe. So definitely 6 lakh unit injections is a strict no-no. And unless you have celiac disease or some malabsorption syndrome where your oral absorption is questionable, maybe in those cases you can give injectables, but other than that, a daily dose is preferred. 2000 per day for infants, 3000 per day for beyond infant.
So that is irrespective of the level. Like suppose somebody has vitamin D level like above 30 is okay.
Deficiency.
Sir, this is for deficiency. This is for deficiency.
Below 12.
And along with vitamin D,
Yes,
you said calcium. How much calcium is calculated calcium?
So that's 500 milligrams. 500 milligrams per day. It's a fixed dose for 90 days.
Calcium comes with phosphorus, and without calcium, only calcium. Like also that is a lot of confusion.
Yes,
it's difficult. Yeah, it's difficult to get a preparation with plain calcium. So whatever calcium you have, of course, elder children we can give tablets, but those infant formulas, they generally come with phosphorus. Yeah.
And again, they state the ratio of calcium to phosphorus. So preparation,
yeah,
whether it is wise to be there.
That ratio is more applicable for infants, but beyond infancy, phosphorus is actually not required. Coming back to the question of which test to be done. So for a plain and simple rickets, if you don't have any clinical clues towards renal tubular acidosis or any resistant rickets, a baseline calcium, phosphorus, alkaline phosphatase, and an X-ray, and probably creatinine to rule out renal failure is good enough. If you have documented a basic calcium profile, ruled out renal failure, and an X-ray to show that there is rickets, just treat with vitamin D and repeat the X-ray probably at 4 to 6 weeks to see the healing line. If the healing line is coming, then you are sure you need not do any further testing. But if the healing line is not coming, then you can give a second round of vitamin D, and at 12 weeks you can repeat the X-ray. But if at 12 weeks also, if the healing line is not there, then one must think of refractory rickets, and then comes the role of all those investigations as 125 dihydroxy or PTH. But routinely 125 dihydroxy is a test that I would not recommend. That's only for those resistant rickets, VDDR type 1, type 2. There you need those tests, but routinely a basic calcium profile along with creatinine and X-ray. Nikhil, you want to add to that?
No, I would agree. And clinically is the most important thing, because vitamin D deficiency will present what we see typically. VDDR will be a much severe form. They will usually have fractures, will present earlier. VDDR type 2 typically will present with alopecia. So clinical judgment will help you. And hypophosphatic rickets will be typically by second year of age. Lower limbs are much more affected than the upper limbs. So clinical clue will give you much more this information than the labs.
And also for the first 6 months of life, will you want that every child should be given vitamin D? That's why IAP recommendations was mentioned. At our time, it was like a vitamin E to be given persistently for everybody. Now vitamin E I never heard of, and I don't know which formula is available. So is the same thing happens for vitamin D and calcium supplements in the next 5-10 years?
So we can have a separate talk on that, but I was fortunate to review the infant part of those guidelines. I was a part of that guideline. I happen to read a lot literature. A lot comes from Lucknow, Delhi, and Pune. And all those guidelines, all those literature have shown that despite of sunbathing, we don't recommend to newborn babies because of the fear of sunburns. But despite of sunbathing for 90 days, at the end of 90 days, the levels are not much. And this study comes from my own parent institute, SGPJ Lucknow. So sunbathing you cannot rely. Breast milk you cannot rely, because most of the mothers are also deficient. So I think there is a definite place for vitamin D supplementation until the first birthday, and the dose is 400 international units per day.
Dr. Tushar, what about the sachet, 60,000 nano or other, once a week or alternate week? Suppose there is not significant vitamin deficiency, but whether they have some standing now.
It's not a part of the current guideline, but we had a lot of discussion on this, because there are a couple of studies from Dr. Raman Marwa and group from Delhi, where they have given one sachet every alternate months to school-going children, school-going girls from New Delhi. And what they found at the end of 1 year was, despite giving one sachet every month or one sachet every alternate month, still 90% of the girls remained deficient.
Okay.
So, but it's not a part of any guideline. Yeah.
Another, I will not with the calcium about this. दूसरा प्रश्न असा है कि IGR बेस मध्ये की suppose they are growth faltering by 3.5 to 4 years, we can supplement with the growth hormone. Whether these childs are growth hormone deficient or not?
They are not growth hormone deficient. Means we first need to see that whether they are growth hormone deficient, but majority of them are not growth hormone deficient. There is an amount of growth hormone resistance seen in these children, sir.
Okay.
And basically it's the growth plate where the problem is. So the problem is either at the growth plate or there is some amount of growth hormone resistance. Deficient, they will present very differently, and they will start presenting from second year on life onwards. They'll be like classic decreased height velocity, whereas SGA will follow along that same line below the third centile or below the MPH. Growth hormone deficiency, you will see a classic faltering.
Because I don't know, growth hormone deficiency may not be more, because these babies will be more common, IGR babies.
Yes.
Because almost 20-30% babies born with a low birth weight here.
50% almost, sir.
Ah.
I think by 10 years, I think SGA will become the most common indication for growth hormone.
Okay. I think we almost covered all questions. And anybody want to ask the questions, they can put their video on and ask us question directly. Everybody can be a moderator here. But it was very excellent, I can say, session.
Dr. Jay, the only thing I saw today, only one patient with 2 endocrinologists, with 2 orthopedic surgeons, with quotations seen a case of skeletal dysplasia. And I don't know whether there will be involvement of rheumatologist in that. And actually, I have mentioned your name, Dr. Nikhil. So probably that patient will be visiting you. So the skeletal dysplasia and 2 endocrinologists, 2 orthopedic, and one had a quotation also stated for the correction of the knee deformity. So let's see what it runs. I don't know. I just was seeing all the papers, bunch of papers.
Any other question anyone has?
So what is the right approach to refer to the skeletal dysplasia? How to go about it? To the first person to see.
Long question for a medical student also.
Gangule sir, Bela madam, please.
Post-pandemic, we are getting a parallel pandemic of vitamin D deficiency.
Yes.
Our patients are having vitamin D3 levels 2, 3, 5, 8. Severe
a lot of rickets in
deficiency.
cyan and soma also, madam.
Yes,
so a lot of
severe
rickets,
deficiency.
hypocalcemic seizures, yes.
So, of course, now because it's a severe deficiency, whether it is better to give them a 3 lakh dose or we should continue for 2 months, like we are saying that give a daily dose, or whether 3 lakh dose is good enough along with oral calcium.
In such cases, if it is symptomatic, then I think symptomatic hypocalcemia, in such cases, Rocaldrol short term will be of more benefit than giving those massive doses. So activated form of vitamin D, if it is symptomatic, so they present with seizures or something else, then a short course of Rocaldrol or an activated form of vitamin D, along with your weekly vitamin D and calcium supplementation will be better. Massive doses, I don't think we should be giving.
But that is a therapeutic dose, not 3 lakhs.
But it's known to cause hypercalciuria. That's what the guidelines say typically. That is what we are really very worried of. So I would typically give a short course of activated form of vitamin D And once the calcium level is normalized, just supplement vitamin D and calcium for a month.
Contrary to normal belief, ma'am, oral works faster than the intramuscular.
Yes, the water soluble one.
Yeah.
And to add one more question, is there really difference between this fat soluble and water soluble? That is promoted by the things. So which vitamin D to be written?
I have only come across one paper, again from Dr. Marwa and group from Delhi, that have stated that 30% better absorption with the nano preparation, but then it's a very small paper, and we still have to have a large data to comment on it. We also have to take into consideration the cost benefit, because the aqueous preparations are slightly costlier. And all said and done, yes, I agree with some question in the chat box or some comment that all these pharmacological supplements are just for the time being, but then we should work on making our lifestyles and diet better. We have surprisingly low incidence of vitamin D deficiency in coastal areas like Kerala, where they eat a lot of seafood. So we have to work on our dietary habits. There is some national program, some recommendation coming on fortification of edible oil with vitamin D. So maybe in future, we have all our edible cooking oil coming with vitamin D, and the incidence might actually come down. But yes, until then, we have to give vitamin D.
I have one more question. So when these, multivitamins, because I had to answer a question from the government regarding 2 products of multivitamins, which had vitamin D3, calcium, B complex, everything added like a cocktail. So naturally, I replied that we don't know whether this mixture is a stable one. What would be the bioavailability of each of these vitamins? And also, long back, I have heard from Khadilkar sir, Abhishek Kulkarni, etc., that we give separate, product or separate medicine of vitamin D3. We do not want to give it as a mixture. We want vitamin D3 as a separate product and calcium as a separate product, and we don't want to mix it with multivitamins. So
to add that, there are 2 mixtures which are having 1000 units of vitamin D, and one other is having 2000 units of vitamin D. With all these mixtures are there. So
yes, the proportion doesn't match. Vitamin A was also there, vitamin B complexes were there, D3 was there, calcium was there. It was something like, a panacea ki you give it to a malnourished child and this will help malnutrition. So of course I rejected that outright. But I'm just telling you ki these people are trying to sell such products in the market, telling ki we have everything in one bottle. And you can give it to your patients, 5 ml OD, 10 ml OD, whatever.
What is your say, sir? What is your say, Dr.
I would agree with Khadilkar sir here. I think we should give it separately, because there is no point in giving, and we do not know how the absorption is, how the bioavailability is going to get affected. So I think you need to give separately, and calcium and vitamin D as separate is always going to be better, because we give it separately.
Many people don't know this. That's why I just...
because they are A to Z, B to Z, C to Z. Like
that product is running very well. But
yeah.
Sir, only the pharma is benefiting.
Yes.
Not the patients.
Yes, agree.
Absolutely.
सगळ्यांनाच होतंय. तर थँक्यू व्हेरी मच. धन्यवाद तुम्हा दोघांना. परत थोडं मराठी बोलूयात.
थोडं मराठी बोलूया आपण काहीतरी. महाराष्ट्र हे आहे.
तर आम्ही काल वर्ल्ड इंटरनॅशनल नर्सिंग डे आपण बघितलं असेल की वी स्टार्टेड ऑल द डेली वर्कशॉप इन मराठी ओनली. So thanks both of you for this wonderful session, and we call back to you again for the calcium and vitamin D.
जय मराठी शब्द एंडोक्रायनॉलॉजिस्टला सांग ना जरा.
हा
आपण या दोघांना विचारू ना.
काय
सगळ्या facultiesला.
आंतरस्रावी ग्रंथी रोग तज्ञ.
अरे बापरे, अच्छा.
गोडबोले सर सांगतील. अंतःस्राव ग्रंथी ग्रंथ तज्ञ असं म्हणता येईल आपल्याला.
विशेषज्ञ. हो.
विशेषज्ञ. So thank you very much. So thanks Nikhil and Tushar for wonderful session, and thanks all delegates for attending a large number, and all office bearers, Dr. Bela, Dr. Naresh, and all of you for attending this session and giving your inputs. Dhanyawad, thank you, and keep attending our Mahaiap sessions. Attend kara YouTube la. There is excellent response. Almost we crossed 5,000 subscriber.
All
Right.
Fridays at 9 p.m.
Yeah.
Fridays.
So
Friday
subscribe
release.
Mahaiap if you are not yet done. MAHAIAP. So whenever you want, all sessions can be seen from the starting point. Like from
Yes.
last 5 months, we are doing it consistently now.
Yeah. Thank you. So good night.
Thank you, sir. Good night.
Good
Good
night.
night, everyone.
Thank you.
Bye bye.
Madam, end kara meeting चालेल.
We can stop now.
Yeah.